I thought I should just share a little bit of experience and a little bit of recommendations, and they are guided by references and they're guided by literature, and it's evidence-based. I will start off very quickly by saying that I hope by the end of the presentation, we will all be comfortable in adopting and applying a practical approach to lipid disorders, especially the investigations and the interpretations of them. It is very important to go through a little bit of background, but I will go through the background slides very quickly so that we can get to the meat of the talk. We will assume that we are comfortable with the passengers, the lipids, that's the subject of the talk, and we are comfortable with the taxis that are carrying these lipids. We call them lipoproteins. They come in different types and structure. They have a specific composition and related to that particular type, and their functions in the body and especially in lipid metabolism. It is very important to paint the picture why we're talking about lipid disorders. They are a risk factor for atherosclerotic cardiovascular disease, specifically cholesterol. And with regards to triglyceride, acute pancreatitis. Of note, they are cardiovascular diseases are a major cause of death worldwide. They are number one and number two, number one being ischemic heart disease and number two being stroke. In low-income countries and middle-income countries, these specific cardiovascular disorders rank third and fourth. But the pattern is changing because of the changing incidence that we're seeing in these low and middle-income countries. There's an increasing incidence and prevalence of obesity, diabetes, hypertension, chronic kidney disease, and lifestyle changes, including smoking. Africa and sub-Sahara Africa have got a double whammy because they have the largest burden of HIV infections and AIDS, and this region runs the largest heart program in the world. Now, it is now public knowledge and it's evidenced that there's increased adverse cardiovascular outcomes in our patients who are HIV infected and those with AIDS defining diseases. That's related to the disease itself and also to the treatment. Now, atherosclerosis being the major component of cardiovascular disease, it is important and fundamental that its prevention is very critical in the reduction of this burden caused by cardiovascular disease. And these interventions can come from health professionals like ourselves. It can also come from public sector, public officials. Individually and collectively, we play a very significant role in these risk reduction measures. My talk is actually centered, still centered on the 2018 guidelines in South Africa. These were set as a joint statement by SAHA, the South African Heart Association, and together with LASA, the Lipid and Atherosclerotic Society of Southern Africa. Now, you will become aware that these associations have always aligned their guidelines with the European Society for Cardiology, and the European Society for Cardiology has introduced new guidelines that still has to be adopted by these associations in South Africa. That's why we're still talking about these guidelines, although there's been a few changes that are coming from the European Society, which is our aligned society. Therefore, you will see a few of our professionals starting to align the guidelines with the European one, and it is still only reasonable to await the recommendations from SAHA and LASA. This is a reference article that I would recommend every general practitioner who's looking after patients has, and especially its references that I will talk to later. Now, before we get to the gist of interpreting these lipid disorders, I think it's very important to take a practical approach and address the issue of when do we do testing for lipids. Obviously, we'll follow the old and trusted approach of history examination and investigations, early investigations guiding the investigations for lipid disorders. But the timing becomes very important, and it is evidence-based. Currently, I think we all accept that for everyone who's over 40 years old, even if asymptomatic, they deserve to have had what they would call the health checkup. So we would do a lipid evaluation for those patients. But there's a point to be made about younger patients. And the reason being that for those who are 20 years and above, as long as they have one cardiovascular risk factor, please do the service of investigating lipid disorders. Now, it becomes even quite a mindset shift when you start considering those who are 8 years and above. Why do you test them? Because they belong or they are part of a family that has presented or is being treated for severe hyperlipidemias, or they have relatives, first-degree relatives, who have got familial or genetic lipid disorders. I will show a slide later on that shows the importance of picking up these young patients at an early age so that they can get the appropriate treatment. Otherwise, we see a lot of early cardiovascular deaths related to lipid disorders. As young as 6 months, for those who have both parents having been diagnosed with this genetic familial hypercholesterolemia. Because if both parents have got that gene, most likely they are homozygous, and therefore they've got even much more earlier presentation of cardiovascular diseases. So it is a mindset shift of deciding when you see your patients, when are you going to test for lipid disorders? We need to start accommodating even these earlier age groups. I want to quickly talk to what are the testing strategies that one needs to adopt. Apologies. In your first visit, what will you be testing for? We accept the stepwise approach of doing total cholesterol and triglyceride. I am emphasizing the additional triglyceride because if you're going to miss triglycerides, you're going to miss another component that can also give you cardiovascular risk disorders, but not so much as what we're talking about, total cholesterol. So both total cholesterol and triglyceride should be involved, should be part of the screen where you are cost conscious, especially our cash paying patients. And you can follow it up if there's abnormalities with the full lipogram. Even with the same request, even with the same sample, it makes sense to then do an add-on with the laboratory because these analytes are quite stable, but not later than 7 days. We still recommend a full lipogram, and I'll explain the reason why, because it sets a nice baseline, and especially for our medical aid patients and those who can afford, because you see the bigger picture. Now, do you do a fasting sample or do you do a random sample? Traditionally, the fasting sample has always been promoted, but the new approach is to even accept a random sample, because I will highlight in an illustrated slide that follows in the next 2 slides why it is also just as important to know what the cholesterol picture looks like, the lipids look like in a random sample. In severe lipid disorders, and where at least the LDL cholesterol is by calculation in that laboratory, the fasting sample is still preferred. And again, in the other slides that follow, we'll illustrate the reason why we want that. Now, the random sample I've talked about, it's the new approach, and also it gives us a little bit more information and much more helpful for directly measured LDL cholesterol. I seem to be frozen. Right. So this is the illustration that I was showing. And if I can illustrate, I don't know whether you can see my pointer. These are the axes that we're talking about. These are the lipoproteins. There's chylomicrons, the very large one, but with low density, very low density. There's VLDL, very low density lipoprotein, intermediate density, low density lipoprotein, and high density lipoprotein. Now, these are the taxis that carry your cholesterol and your triglycerides as well. Now, what do we get when we measure total cholesterol? When we measure total cholesterol, we're getting the whole picture of your blood sample. It's part of your lipid profile that we're talking about. What do we get when we measure HDL cholesterol? We're measuring the component that is carried in the taxi called HDL. Okay? In your LDL, likewise, by definition. And what has been introduced lately are the calculations that can be done from this lipid profile. And one of those calculations is called the non-HDL cholesterol. The reason why it's important to separate this is because HDL cholesterol is always seen as cardioprotective. It's the good cholesterol that you need in higher quantities. And the rest are the bad cholesterols that you have got even much more adverse effects on the body. So that ratio has become one of the newer calculations that are considered even in treatment targets. Why we prefer doing even a random sample is because if you look at these taxis that we're talking about, the chylomicrons, the very low density lipoprotein, intermediate density, low density lipoprotein. Here, the yellow reflects the cholesterol that is a component or that is carried in those lipoproteins. If you look at the chylomicrons, which are the transporters of exogenous cholesterol via the lymphatic system from the intestines, via the lymphatic system into the cardiovascular system, you will see that the cholesterol is a small fraction. It is predominantly triglyceride rich. But after it has entered the blood circulation and metabolized, it ends up being a chylomicron remnant, which is very rich in cholesterol. If we take a fasting sample, we miss this chylomicron remnants, which contribute also to the cholesterol and lipid profile and the disorders that follow thereafter. So this is one of the motivations that we have in place to say even a random sample is giving us a better picture. But remember the proviso there that if you're calculating your LDL cholesterol, it might be wise to rather do a fasting sample. Now, this is an issue that the laboratory needs to discuss with its clients to say our methods of lipid of LDL cholesterol is a measured one versus one that is a directly measured one. This is the calculated LDL formula that has been around for decades. There are many more new ones that have come up now, and there are potential candidates to overtake this old calculation. But it still has stood the test of time because what it says is derived from the fact that your total cholesterol is a contribution of LDL cholesterol, HDL cholesterol, and VLDL cholesterol. All that happened in this equation, the wise men changed the subject of the formula and made LDL the subject of the formula instead of total cholesterol, and that's why the HDL cholesterol is deducted from that. The challenge is that most of the laboratory methods do not measure VLDL. It is therefore estimated from your triglycerides that are measured by the laboratory. Traditionally, it has been accepted that the ratio of triglycerides, the amount of triglycerides that are in the VLDL, the amount of cholesterol that is in a VLDL lipoprotein is 1/5 of the triglyceride. It's a triglyceride-rich lipoprotein, and triglycerides are 5 times the amount of cholesterol in that lipoprotein. So it is therefore based on that particular ratio that Americans preferably took a nice round number of 5 and made triglycerides divided by 5 as an estimate of VLDL. The rest of the world, which is using international units, we were stuck with the fraction of 2.2. Therefore, we can calculate VLDL by measuring LDL. We can estimate VLDL cholesterol by measuring triglyceride and dividing it by 2.2 in millimoles to be able to get the final answer for that. I'm spending a little bit of time on this so that we can understand and not confuse that triglycerides are part of the lipid are part of the cholesterol component. They are part of the lipid profile, but they're also useful in calculating LDL where there is no available directly measured method. Now we know which age we need to intervene at and on your first consultation. Now, what happens then on follow-up consultations? And for those patients we have identified as having lipid disorders, those who have lipid disorders and you have decided to initiate treatment on, your recall date is 3 months. So now we're structuring how you're going to look after your patients who have got these lipid disorders. If you change treatment in a patient that's not actually reaching the goals that you want, you will still recall that particular patient in 3 months' time to come and do another test. Now, we'll talk about what test you'll do at follow-up, but it's also just as important to then say, when do you recall the patients where you have just done lifestyle changes? And when do you recall those patients where they have reached already treatment targets? The recall date is a little bit longer. So you'll call them twice a year, which is every 6 months. They come for your repeat follow-up bloods. And what are these bloods that you're going to do on follow-up visit? Now you know the lipid profile of this particular patient. LDL cholesterol is sufficient because now you are monitoring whether you have reached target or not. It is practical. Now we're talking only for the patients where it's a cholesterol disorder. Obviously, if there is a triglyceride disorder, you have to also do a follow-up of triglyceride as well. But for those patients where it's a pure cholesterol disorder, your follow-up recommended test is only LDL cholesterol. It's a prudent way of managing your patient and also managing the benefits of your patients. Occasionally, you can do total cholesterol, but in patients where you will do total cholesterol, it's much easier. It's difficult to interpret whether are they falling into the treatment achievement targets or not, unless you have established a relationship that when the cholesterol is 5, the LDL total cholesterol is 5, the LDL cholesterol is 2. That takes a repeat number of samples before you're comfortable that for my patient, when the cholesterol is 6, the LDL cholesterol will be 2.5. Therefore, you can measure just total cholesterol without measuring LDL cholesterol. Once in a lifetime, your patients deserve to have a lipoprotein A. But we also recommend lipoprotein A as an important marker for patients who have got severe hyperlipidemias. There are now treatment targets for these lipoprotein A that have you reached treatment target or not. That's only with the new guidelines that are to be still adopted by SAHA and LASA. When you refer your patients, it's very important also not to hog on patients who have got severe hyperlipidemia, not to hold on to patients who have got genetic lipid disorders, and those who are not getting to treatment targets, those we call them having high residual cardiovascular risk. And these specialists will then recommend or do further specialized tests, which are listed there, We won't go too much into the details of that, but you should know there's additional tests that for some practitioners who have got experience in looking after lipid disorders, they can also request them, but we can measure lipid electrophoresis. We can assess lipids using gradient ultracentrifugation, and we can actually even do tandem mass spectrophotometry with separation with liquid chromatography for apoprotein analysis. And there's further genetic tests, especially for those patients who are suspected to have primary lipid disorders. I've talked briefly about these calculations, and I won't like to stay too long on them. I would like to just go through the meat of the criteria. Now that we know when to test and what test to do on the first visit and follow-up visits, this is the crux of it. By the end of your examination or your assessment of your lipid profile that you've requested from the laboratory, you should be able to answer all 5 of these questions. What traditionally has been happening in clinical practice is to stop somewhere halfway and quickly get to interventions and treatment. We need to take it through right to the end and include risk profiling our patients. The first question is, confirm whether there is hyperlipidemia, yes or no. Number 2, if it is there, how severe is it? So you need to know the severity, because those are the ones you need to pick up early and know that those need highly specialized intervention because they have a severe morbidity and possible mortality at a much earlier age. Also, further to that, you will, from the picture of your lipogram, be able to describe what phenotype of hyperlipidemia is it. Is it predominantly cholesterol? Is it predominantly triglyceride? Or are they combined? And then go further and ask yourself, what is causing this hyperlipidemia? And this is the critical part, that we shouldn't just start treatment without trying to investigate what's the cause. Because some of these lipid disorders can just be managed by controlling your diabetes, managing the secondary causes of your lipid disorders. So it is critical to find yourself, to try and find the reason. Sometimes you don't, and sometimes it requires referral where you suspect that this probably is a genetic disorder and therefore a primary hyperlipidemia and needs further investigations, including molecular investigations. And the last part I've just emphasized, we have to risk profile our patients because we need to know what are the chances of them getting a cardiovascular event in a 10-year period. Also, those that do not require risk profiling, that require already classifying themselves, those patients as either a very high risk or high risk. I'll talk to that now. So here we go. When do you say the patient has got hyperlipidemia? For total cholesterol greater than 5, you know that it's above normal or above expected range. Therefore, it is high, so it's a hyperlipidemia. For triglycerides, if it's greater than 1.7. When do you say it's severe? Hypercholesterolemia or hypertriglyceridemia. Already you know triglycerides are greater than 1, but are they greater than 5.6, the triglycerides? If they are greater than 4.5, the first step is we have to notify the clinicians that are referring work to us that if we are using a calculated method for LDL cholesterol, that method cannot be verified. That result cannot be verified with certainty because now the ratio of your triglycerides to cholesterol in that VLDL has changed because now your triglycerides are higher, but you're still dividing by 5 if you are in the US, 2.2, the rest of the world. Therefore, you will overestimate your VLDL fraction of cholesterol. By doing that, you are underestimating your LDL cholesterol, if you remember the formula, because your VLDL is deducted from your total cholesterol to get the LDL after also deducting HDL cholesterol. So it becomes very important to also note that as triglycerides get greater than 4.5, the calculated method becomes weak in estimating LDL cholesterol. So it's preferable to then do a directly measured method. The clinicians, the laboratory practitioners should have got a right of actually informing the clinicians about that shortcoming. The second part about lipid, about cholesterol, how high is it? For adults, anything greater than 7.5 is considered severe. And therefore, in these patients with severe hypercholesterolemia, in our heads, we're already thinking, could it be familial? Could it be genetic? And these are the patients we need to refer early and not try to hold on for too long, because we need to pick up the familial ones, the genetic causes, because they are the ones that we are under diagnosing. Having classified whether your dyslipidemia is severe or not so severe, mild or moderate, it's further important to classify it that what phenotype is it? Is it predominantly a cholesterol disorder? Is it a mixed disorder? Or is it predominantly a triglyceride disorder? Because the causes vary and they differ. The next question is, could it be secondary? That's the first question we ask before we say, could it be primary? Of course, we are suspecting primary hyperlipidemias in those that are severe. Therefore, we need to take the appropriate actions. The secondary ones need to be excluded. The diagnosis of exclusion requires that you have a bit of background information about what are the most common causes of secondary hyperlipidemia. And what causes these disorders? There's an alteration somewhere in the synthesis or in the processing or even in the clearance of your lipids, lipoproteins, or the apolipoproteins. Secondary hyperlipidemia, you will suspect and you will diagnose because you have taken a history and you know the chronic diseases that the patient has, or you know the medication that the patient has, and therefore you cross-reference with the most common causes of that. Or after an examination, you have assessed the anthropometric measurements of the patient, or you know you have diagnosed hypertension, that it is a severe hypertension in this particular patient, or you've done laboratory investigations. So when we say in our comments in the laboratory, exclude secondary hyperlipidemias, these are the things that we are highlighting for you, that be on the watch out, that could it be a chronic kidney disease? So have you done your renal function test? Could it be a thyroid disorder? Have you done your TSH, or if it's abnormal, followed by 3T4 or a full thyroid function test? Are there any tests that you've done? Is the patient pregnant? Is there a liver disorder? Is there glucose intolerance you'll get from doing secondary tests, because you want to exclude secondary causes of lipid disorders? Here, this table just classifies the common causes of a predominantly predominantly hypercholesterolemia, a mixed one, or a predominantly hypertriglyceridemia phenotype. And you will see some of the disorders cut across the spectrum. Diabetes is one that is very notorious. It can give any of the pictures. It varies from patient to patient. Some of the chronic medication also move across the different categories as well. And note chronic renal disease, chronic kidney disease as well, can either present with a hypercholesterolemia or a hypertriglyceridemia. So that's secondary hyperlipidemias. And for primary hyperlipidemias, you also need to have an approach. Yes, they are complex, but you can simplify them by just having an approach. First of all, classifying the phenotype. Then it narrows your spectrum of what could possibly cause that. You can suspect that, diagnose primary ones from the family history that you have taken during the initial examination or the initial encounter with your client. From your physical examination, you will see your tendon lesions or your periorbital lesions, or the lesions that you'll see in your extensor surfaces of the limbs, or especially the Achilles tendon. Please examine that, and also your assessment of your fundi. You will have bumped into your corneal arcus cornealis. Sorry, the electricity has just come back now. I hope it didn't trip that. There's additional investigations that one does as well. And these will be part of that particular follow-up. And these, we are saying that highly recommended if they are done under a specialist guidance. Of course, if you're comfortable with doing them yourself, but you just need to make sure that you're following the right approach with that. One of those that I spoke about earlier is lipid electrophoresis. And lipid electrophoresis patterns that we see are similar to what are illustrated in this particular slide. It's a very old technique, but still very commonly used, especially in primary hyperlipidemias, hypercholesterolemia. And this is what we then do after doing those those lipograms and those lipid electrophoresis gels. We are able to then try and classify based on the pattern, whether it's a type 1, 2A, 2B, or 5, based on the distribution of the different regions of the electrophoresis gel. You are able to then even suspect the diagnosis. And you will see here a spread of the different conditions, whether it's a familial problem related to high chylomicron, or whether it's predominant in type 5, you'll see a predominance of triglycerides, predominantly an endogenous or familial hypertriglyceridemia. These steps, there are many steps involved before you come to that final diagnosis. One of it is what we call a standing test, where you just take the blood sample. After having spun it down, you leave it overnight, and then you see whether the ability that has made you suspicious of a lipid disorder when you drew the blood, does the turbid serum separate, or does it stay turbid throughout the overnight stay? Or do you see a creamy layer on top, or do you see a creamy layer with a turbid bottom, or is it just staying clear? And using those combination of tests, you are able to classify and decide which one to go. So the classification of primary hyperlipidemias is usually by phenotype. It's very important then to then follow that particular approach, because if it's predominantly a hypercholesterolemia, you will then classify the common disorders seen, the genetic disorders seen in severely high cholesterol levels as either familial hypercholesterolemia, FH, and this is one of those that are topical in South Africa because of the inheritance and the history of them, and the other one being the where you have HDL cholesterol being very low, and that also can contribute to a very high hypercholesterolemia. Triglyceride, we worry about the metabolism, the breakdown of triglycerides in circulation, and the enzyme that's responsible for that breakdown is lipoprotein lipase. It's called LPL, and if it's deficient, or its co-activator, which is called apoprotein C2, you find that the triglycerides are not being broken down, they are not being stored, they stay in circulation, and therefore they remain very high. The second one being familial hypertriglyceridemia. And the last one is a mixed picture that can be classified as a dis-beta lipoproteinemia or a combined hyperlipidemia. The terminology is not that important, but the first step is identifying where the problem is, classifying it as severe, knowing that most likely it is a genetic disorder. Simon Broom introduced a clear classification of familial hypercholesterolemia. And you can definitely diagnose familial hypercholesterolemia in patients who have severely elevated cholesterol and they've got clinical findings, where, or alternatively, there's a first degree relative who also has familial hypercholesterolemia. Further to that, you need the DNA evidence, the molecular test for noting the mutation that happens with the LDL receptor or the apolipoprotein B ligand, or there is another molecule we're going to talk about. It's a trafficking molecule. It's called PCSK9. And that gene, if it's mutated, can also cause lipid disorders. The probability being high of familial hypercholesterolemia is also listed here. You don't have necessarily genetic evidence, but you have these possibilities where you have severely elevated cholesterol, a family history of another, not necessarily the familial hypercholesterolemia, but another cardiovascular event at an early age, or before the age of 60 for a first degree relative. And the other one specifies mainly the level of the high cholesterol in the patient or in the family as well. Hypercholesterolemia, this slide now gives the details, and this is the one we'll just skip so that you can digest it at your pace. This is the slides. The slides are going to be available on the ECIPA website for your support so that you can understand them. If I were to go through each and every one of these familial disorders, I think we'll get sidetracked, because I just want to get to the last part, which is the one about risk profiling the patient. So I'm going to talk through these primary disorders, examples of primary disorders very quickly. The first, cholesterol, hypercholesterolemia, that's primary, has got a primary cause or genetic cause, is the common familial hypercholesterolemia, where the genetic mutation is with the LDL receptor. Inheritance is known, and the pattern is known. And we have just talked about the Simon-Broom criteria for identifying it. The second component of it could be related, not necessarily to the LDL receptor mutation, but a defective apoprotein B. Now, the apoprotein B is the ligand. It is the protein that now attaches to the receptor, the LDL receptor. So if the receptor is mutated, or the ligand that binds, that clings to this receptor, is mutated as well, you will then understand that it can cause poor clearance of the cholesterol and its lipoprotein from circulation, and therefore you'll have elevated cholesterol levels. The last one is the one that's related to this chaperone molecule. It's called protein convertase subtilisin / casein type 9. It's a long word, but you have heard about PCSK9, especially the PCSK9 antibodies, or that are helping to clear the antibodies as a strategy for treating some types of hypercholesterolemias. Now, if this transporter or this chaperone molecule is mutated, and most of the time it is a gain of function, meaning that it becomes hyperactive, what it does, it clears quickly your receptors. So the problems with hypercholesterolemia can be the receptor itself, in the LDL receptor, it can be the binding molecule that binds into the receptor, or it can be the chaperone molecule, PCSK9, that clears the receptors from the surface of the liver so that they're not available to clear the cholesterol-containing lipoproteins, and therefore your cholesterol remains high. It makes sense. This diagram or illustration in this slide takes us through exactly how LDL cholesterol and LDL cholesterol is cleared from circulation. Actually, even just the LDL lipoprotein itself is cleared from circulation, and how it binds on the surface of the liver of the hepatocyte, and how it undergoes recycling. Sorry about that. How it undergoes recycling, that it comes back to clear more. So the chaperone molecule, PCSK9, is responsible for diverting the receptor so that it goes to the lysosome and is broken down to its components. And therefore, it's not available anymore to go back to the surface so that it can clear more LDL cholesterol lipoproteins, containing lipoprotein. So the next slide is more specific and illustrates the presence of the PCSK9, the chaperone molecule. This is under normal circumstances here, okay? A is under normal circumstances, So this is actually from pharmacology, where they illustrate that if there is a gain of function and these PCSK9 available in abundance in circulation, what they do is they divert the LDL receptors that they go for to the scrapyard, basically, which is your endosome and a lysosome, and it's broken down into individual parts, and the parts are never wasted in each cell in the human body cell, and it goes for to do other functions that are meant to that. So you find that these receptors are no longer available in abundance on the surface to clear the LDL cholesterol and also the LDL lipoproteins, Here, what it illustrates, because it's from pharmacology, the introduction of monoclonal antibodies that bind and prevent this recycling of going to the scrapyard, so that you have the LDL receptors in abundance, and therefore you can clear enough of the LDLs in circulation and lower your cholesterol amounts. This slide only shows basically the taxes that we talked about before, and it describes basically and shows the different apoproteins, which are the ligands that are there. And what I want to illustrate on this slide, why we say HDL cholesterol is the good cholesterol. Note that it's the only one that's got the ApoA1. All the others are called ApoB containing lipoproteins, and B always assume bad. So these are bad cholesterols, and the ApoA1, which is only found in abundance in the HDL, is the good cholesterol. Right. So earlier on, I indicated why it's important to measure to assess lipids in different age groups. What this slide illustrates basically is the patterns of what would happen in a homozygous familial hypercholesterolemia patient who has not been diagnosed. When do they reach threshold cumulative, that's cumulative over the years, cumulative cholesterol levels that are detrimental to health and actually become fatal? In a patient who's got homozygous familial hypercholesterolemia, you can see they will reach that critical age, that critical cumulative level earlier on, 12 and a half years. It's important to pick them up at less than from 6 months onwards. Otherwise, they will easily pick up cardiovascular disease that will cause early childhood death, as much as that for homozygous. So very critical to pick up these genetic disorders. For the heterozygous, may not look so bad, but 35 is still a very productive year. We're picking up cardiovascular disorders and also mortality related to that. So it is important that we pick these patients up early, and this slide just illustrates early pickup, early treatment, what it does. With intervention, you can see the years are actually stretched out a little bit longer before they reach critical. The next couple of slides also illustrate the hyperlipidemias, and I'm going to go through these quickly because they're not as commonly talked about, like familial hypercholesterolemia. You can have a high cholesterol because the HDL is very low because of different reasons. Okay, you can also have the other side of the spectrum where the triglycerides are very high. Remember, when the triglycerides get greater than 7.5, they are severe. And we know that it's a critical result at 11. You can have acute pancreatitis anytime at that particular level. And these are the causes, the two causes for the familial hypertriglyceridemia. And you have the combined picture here of mixed hyperlipidemias, for where both the cholesterol and the triglyceride component is elevated in familial cases. The last part of the 5-point approach to diagnosis involves risk profiling your patient. You must know the modifier. These are the established cardiovascular risks for cardiovascular disorders. These are the established risk factors. These are non-modifiable, and these are modifiable. It's very important to approach them like that, because when we do lifestyle interventions, we are addressing the modifiable ones. It doesn't mean that it will affect this, but it makes a major difference in your management. Also note that there are emerging risk factors that we talk about, including impaired fasting glucose. Before you even get to diabetes, if you've done your oral glucose tolerance test, this is the only time where you will actually pick up your impaired fasting glucose, because it's a rather a complex, a combined interpretation of what your fasting glucose is and what's your 2-hour glucose like. There are other factors that are emerging, chronic inflammatory disease also being part of that picture. So when do you do risk assessment, and when do you not do it? So for patients who already have had an incident, an atherosclerotic event or a cardiovascular event, those already are classified as very high risk, and therefore they don't need even risking, because the risking is for primary prevention. But if the event has already happened, that patient immediately falls into the category of very high risk, greater than 30% chance of having another cardiovascular event within 10 years. So these are the patients that are classified under these very high risk, and you don't even need to go and do calculations. Those who have had atherosclerosis, whether it's a coronary artery disease, cardiovascular disorder, or peripheral vascular disorder, both of your diabetes appear in here with one risk factors or with albuminuria, or a high albumin creatinine ratio, or a high albumin protein creatinine ratio. So it's important to do those measurements, and I'm glad to see that a lot of our clinicians and our GPs are actually doing the urine assessments. Genetic dyslipidemias don't require to be calculated risk because they already are very high risk. Those who have got severe hypercholesterolemia, we have talked about them, they fall into this risk, and that's where we suspect even familial disorders. And those who have got end-stage renal failure, those fall already in that risk. Also, there are others that do not require risking, but they don't fall into the greater than 30% risk. They fall under high risk of 15 to 30%, where your hypertension is severe. Either your systolic is greater than 180 or your diastolic is greater than 110. Those patients do not even require risk calculations. They already fall into this category. So do not waste time. You know these ones, emergent. You need to make an intervention. Type 1 and type 2 diabetes without any complications, meaning that even if the ACR or the PCR is not, the protein creatinine ratio, the albumin creatinine ratio is normal. And then you have now your patients who are falling into this category of grade of eGFR of between 30 and 50. Now we're talking about 3A and stage 3A and stage 3B chronic kidney disease. Ones that require you to do some meds will fall into this particular category. All others who are having abnormal lipids and abnormal, especially cholesterol, will fall into. Now you have to do your calculations. We still rely on the old and trusted Framingham 10-year risk assessment charts. There are many other charts that have been introduced, especially in Europe, but we still rely on this to calculate. And you can, even from calculation, be able to identify very high-risk patients based on the score, high-risk patients who are between 15 and 30%, having a risk of 15 to 30% of a cardiovascular event within the 10-year period, or moderate risk and low risk, depending on the percentage in there. This is what the tables actually look like. What is important is two things. Number one, there are different tables for different genders, male and female, okay? Number two, you need to have now the data that you have from your history examination and from your results to be able to do that. And what do you need? You need your lipogram. You need to know the age of the patient, obviously the gender. You need to know your total cholesterol, the HDL cholesterol, and the blood pressure measurement, and the history of smoking. Now, what is important is that the scoring is not the same in both genders. It's different. And also the age categories may differ, and the scoring may differ, the ranges may differ across one another. So you have to have two separate charts, or a chart that has got a gender classification, so that you can be able to get the correct score. Once you have scored your patients based on how many risk factors they have, and also the severity of each risk factor, you will then have a total. Now, After having had a total, you then go to your table again. And all of these tables are available in that guideline that I shared with you earlier, the SAHA and the LASA guideline. You get a score, and the score will then indicate the risk that is linked to it. You'll see if your total score is 7, it is the risk for cardiovascular event in 10 years is 5.6%. It is color-coded. It will show you low risk, which is green, moderate risk, which is yellow, high risk, and very high risk like that. So it correlates actually to the color coding and the score in there. In the last part of it, obviously, once you have put your scores together, it is important then to then classify what action you need to take. So your final diagnosis for your patients with abnormal lipid profiles will include answers to all of these so that you can get to the bottom of the things. The further management, unfortunately, I won't spend a lot of time here, but in all of the lipid disorders, therapeutic interventions lifestyle interventions are essential, especially to address the modifiable risk factors as well. So it is applied across the border, and occasionally you have to make decisions when to start statins. And unfortunately, that discussion is outside the ambit of this talk, In the end, every patient's file who has got a lipid disorder must have this score, because this becomes your baseline score of saying, how did the patient score for age, total cholesterol, smoking, HDL, systolic blood pressure, and the total score? Because that score is going to be your initial score. And when you do your reviews, you will then assess again and score the patient, so that you need to see a change in the scoring as you go along that indicates you are improving, you are addressing the issues that are there. The final score that you have, the percentage, will assist you in making the correct decision on what interventions to do. Number 2, your follow-up blood test. What is your treatment target? Now, the treatment targets have changed a bit. Let me skip to the next slide, because this one is linked to the 2018 SAHA and the LASA guidelines. These are the treatment targets. But there's been a change in this treatment target. Why? Because of 1 or 2 slides that I'm going to show after that. But for the very high-risk patient, it is important to note that our treatment target is less than 1.5. For all these treatment targets, we also accept a drop of about 50% from the initial LDL cholesterol. So it means we're going in the correct direction. If that doesn't happen, we call that a residual risk. And what's the problem? The problem is that currently, the challenge we're facing is that even patients who are assumed to be, or who we think that already have reached the treatment goals, they still present in casualty. And these are the slides that show actually the evidence that says these patients who we thought had reached targets are still presenting with cardiovascular events. So there's something that we're missing. So what do? The first thing we did is to then adjust and look at the new treatment targets. Your 1.8 millimoles target for LDL cholesterol in the severe in the greater than 30% risk category then has been adjusted to become 1.4 millimoles. So your treatment target for those now has been reduced in this guideline so that it can accommodate and try and address that. The other component of it is an ongoing issue, that are we really testing, or are we really testing the correct biomarkers for assessing cardiovascular? That's a question that us researchers and colleagues in this field are grappling with, and we're looking for newer approaches. And part of those newer approaches are looking not just at tests that can be run in the small instruments, but we can run them on liquid chromatography, mass spectrophotometry, tandem or not tandem. Okay. So in summary, cardiovascular disease is a leading cause of death and disability worldwide. Up to 80% of cardiovascular-related premature deaths are seen in young people. So it's very important to pick them up early and start investigating early. Lipid disorders and other risk factors for cardiovascular are underdiagnosed in our region. And these guidelines are helping us to try and get to there, and high pickup rates, high interventions, and address those issues. And there's many options available in terms of testing And I'd like to thank you for listening and being patient throughout my presentation. I hope after this presentation, we can adopt a much more practical approach and we can reference from the guidelines and follow a structured approach in managing lipid disorders. Thank you very much, colleagues.
Thanks very much, Sipho, for a tour de force on practical management of hypercholesterolemia. That was excellent. I think Sama should actually give us 4 CPD points for this talk. That was excellent, Sipho. Thanks very much for the time that you took to prepare these slides. I'm sure you've been very busy with the lab. I'm going to open the floor for questions. Colleagues, you should be able to unmute if you have a question or stick your hand up. Your virtual hand. Who's first?
Jeff, Shiva, yeah. I don't have the hand up thing on me. I don't know why, but can I ask a question?
You may go ahead, Shiva.
First thing, welcome back, Sipho, to our region. We really hope that you will stay along and have a fruitful and fulfilling time here. Secondly, thank you for this comprehensive presentation. You know, I'm now mostly doing obstetrics, so it was a tour de force for me, as Jeff said, to get a recap of all of these things all over again. You know, it reminded me of the medical school days of my Fredrickson's classification, phenotypical classification, and Simon Brown classification. But coming to my question, this is the end point of treating is not to treat the risk of hypercholesterolemia, because what is the end point? The end point is a cardiovascular event. And then we have to then develop an algorithm or something that measures risk of a cardiovascular event. Now, all we have till now is the Framingham 10-year risk analysis that is done. But the Framingham 10-year risk analysis is frightfully short in an algorithm. It doesn't take into consideration quite a lot of things. It just bases itself mostly on age, cholesterol, male, female. But we know that there are many other factors. If you are to look at a cardiovascular event like race, if you're an Indian group that you come from, whether you have on ARVs, renal function, thyroid function, whether you're pregnant, non-pregnant, the number of pregnancies that you had. So I'm asking, is there any, because I'm doing this now in fetal medicine, is there any algorithm coming up that is comprehensive in measuring risk analysis for a cardiovascular event that includes lipid profile? Because you must understand the lipid profile weight for a cardiovascular event is not more than 12 to 15%. There are other risk factors in it. So you've got to get an algorithm that takes all of that into consideration. Is there anybody working on something like this, like we do in fetal medicine? Because that will be very interesting to know.
Sipho?
Okay. Siva, for the kind words, and also also you are on point, Siva, in mentioning the shortcomings of the Framingham risk chart. It is an old chart, but just like the calculations for LDL, they are always tested against the new ones that are available. The European Society has actually introduced a different model for calculating risk. It does have new entries that appear in there. And one of them that is appearing in there, unfortunately, in risk-constrained countries becomes a challenge, which is the introduction of lipoprotein small a. I don't know whether we'll just flash back and remember that slide where I showed the different lipoproteins. Lipoprotein small a is an LDL-like lipoprotein, but unfortunately, the current methods that are used routinely in most of the laboratory is not able to measure that. You need to measure it separately using liquid chromatography, tandem mass spectrophotometry, which is not a universally available method, and therefore it lacks that component of being available to everybody. And that's the resistance that, or the delay that has happened with SAHA and LASA in adopting some of the newer guidelines, because they are not universally available to everybody. So yes, I agree with you. There's lots of limitations on the Framingham risk chart, but there's also reasons why SAHA and LASA sticks to it, because it tends to be universally available. Yes, there's been newer developments with lots of other risk factors. That's where now clinicians are not using it only as the only tool, but there's also other tools that and other charts that are being used in line with that, which fall under your cardiovascular disciplines. And they are more clinical and they're not laboratory based. So they tend to use Framingham in combination with the clinical ones, including the ones that they use in admissions of patients for cardiovascular events, and also risk profiling the patients who are coming through in casualty. So they are available, Siva, but at the moment they are not structured in this particular discussion point. Thanks.
Sean, take over the Q&A, please.
So sorry, Jeff, a quick one. The reference I've included in there, the European one that's got 2019, is also the reference article where you'll find that new classification. It tends to be a little bit confusing, but for those who have got special interest in alternative risk profiling, that article, the 2019 European Society for Cardiology, includes that new risk profile. Sorry.
Are there any further questions for Dr. Dlamini? I see in the chat room there, Dr. Soga and Dr. Farouk says, excellent presentation. Any further questions?
Sean, from my side, I'd like to ask Sipho, I'd like to just stir a little bit, Sipho. There's a whole contrarian school of thought, even at the level of cardiologists, that subscribe to the view that cholesterol is not the causative factor in atherosclerosis, but rather inflammation that is due to high sugar levels, high sugar intake, high carb intake, and then the inflammation causes cholesterol to adhere to the inflamed areas. What are your thoughts on that? As I said, I'm stirring.
It's okay, you can stir it. So if you were to look at the model of how an atheroma is formed, we usually say the culprits and the risk factors are what damages the intima of the vascular circulation. So what your hypertension will do, it strains and stresses the intima of your cardiovascular system. What does it do? It creates pores in there, or weaknesses or cracks in that. Number two, the next step in atheroma formation is now the trapping of small, dense lipoproteins, or the chylomicron remnants. That will then enter the submucosal space. Now, that is then seen as a foreign body. So I'm painting this picture to then say, there's a lot of players there's lots of factors that are at play. The primary problem does not, the primary role of cholesterol is not wavered, because to form, once the small dense lipoproteins or the chylomicrons enter, they will be oxidized because they are seen as foreign, and the macrophages move in and they form cells. That's the first blip that will happen under submucosally, and it will then grow. The inflammation part only plays a role in rupturing of that atheroma. It also makes further damage. It also adds to further damage of the intima of the vascular system. So it's not either or, but it's now the finding of additional factors that are also at play. It is for that role that we have what we now call emerging risk factors, and one of them being autoimmune disorders playing a significant role in that. It is for that reason we also start to consider inflammatory markers in introducing, which goes back to the point that Sipho was making earlier, that there should be additional biomarkers that are now included in this equation so that we can get a better picture of that. So inflammatory biomarkers have got an additional value in you identifying the patient who's even at most risk of rupturing that atheroma. Okay, so I hope that answers that. Both of them is not necessarily either or, but the primary entry or the primary thing to form a foam cell and to have that small blip that will give an atheroma, you need fatty cells in the fatty tissue.
Thanks, Sipho. Over to you, Sean.
Dr. Dlamini, if I understood you correctly, you said that we don't have to specifically ask for a fasting lipogram anymore. Is that correct?
Yes, it is now the new way of thinking, but it's got provisos, yes.
So how does that affect the accuracy in terms of the total cholesterol and the LDL, and by what margins?
So that's a very good question, John. Evidence has led us to making that decision because there are changes. We're not saying there's no changes, but what we're saying, those changes are not affecting medical decision points. They are technically not misclassifying our patients either in terms of risk categories or in terms of classifying the patients as being falling into the severe or in the moderate or in the low range. I'll give you an example specifically of LDL cholesterol. The changes are less than 0.8 millimoles that will happen if you do the random one versus the fasting one. Now, having said that, please note that in the non-fasting sample, your main contributor to the changes is exogenous lipids, which is predominantly the fraction that falls into the kilomicrons category and very low density lipoprotein as they are transporters. So it would be your triglycerides, which are predominantly high in those two fractions of those lipoproteins. So you find that with the triglycerides, especially when the triglycerides are high and we look at the collection time of the sample and it's not in the early morning period or it's well after 2 or even in the evening, our suspicion is always to say that maybe it could be a non-fasting sample. And you might have seen 1 or 2 comments for those who are already using the laboratory that says that a non-fasting sample, but the point is that it won't change your classification of the patient. It just changes with the fraction. So we're still recommending the traditional approach because a lot of the laboratories are still calculating LDL cholesterol, including our laboratory, but we want to introduce the directly measured method. But it tends to come at a bit of a cost because it's an additional expense. At the moment, we do not even charge the LDL cholesterol that's calculated because it's a calculation. It's like anion gap. We don't charge anion gap. We don't charge globulin gap because it's a calculation from already existing results. So the other thing about a non-fasting sample, remember what you said, it picks up that remnant kilomicron contribution of cholesterol because in a non-fasting sample, you are able to include it in the calculation. So we want to pick up the higher ones because those are the ones which are almost as close as the same size as small dense lipoproteins. And those are the ones which will permeate through those damaged intimal walls in the cardiovascular system. Thank you.
Okay. Thank you very much, Dr. Dlamini. Any further questions for Sipho?
Siva has got his hand up.
Okay, go ahead, Siva.
Jeff, just to answer your question, the issue is that we have to look at the endpoint, and that's the point I was writing with Sipho. The endpoint here is to prevent a cardiovascular event, namely myocardial infarction or a stroke. Those are the two events that you want to prevent. Now, we've been sold too much that cholesterol is the major factor, contributing factor to a cardiovascular event. Latest thinking is thinking, and Sipho will correct me if I'm wrong, but that's what I read. The latest thinking is that cholesterol and lipid profile contributes, except if you're talking about familial triglyceridemia or familial disease or something like that, but on a general basis, contributes only to 12 to 15% of the risk of a cardiovascular event. So if you take it, even if the upper limit of 15, you've got 85 other percentage of other risk factors. And while you go mad treating the cholesterol, you miss out the other 85% of the risk factors. And that is why the Framingham algorithm, which based itself basically came out from people who are marketing anti-cholesterol drugs, based its risk profile on mostly on the cholesterol levels. And did not look at the other factors too much. And therefore, you need a more comprehensive algorithm that measures the cardiovascular risk factors, which you'll have to take into consideration your age, your race group, whether you're Indian, your height, your weight, any illness profiles, modifiable risk, non-modifiable risks, and other things. And you have to come out with a more comprehensive algorithm that can measure the risk for a cardiovascular event than just cholesterol itself, which just contributes to 15%. And that is why the cholesterol treatment got a bad name, because it got overemphasized at the expense of the other 85% of the risk factors. And that is why it needs to be relooked at, so that you look at it, when you don't get too close to the trees and you miss the forest. So you look at a broader picture and you'll try to look at it. And that's the thing, that's where the focus wants to come back. But on the second thing, I wanted to say on a very light note to Sipho. Sipho, I noticed that you put modifiable and non-modifiable risks, and I see you put age under modifiable risks. That gave me a lot of hope, because now I can just say age is a fact, is a number, and I can put it as modifiable just like that. But lastly, I wanted to say, Jeff, must just give Sipho some chance for marketing, because I want to know whether he's coming to UTNEG and what services does he provide, and whether it does the things that we do in fetal medicine. Thank you.
Yeah, also I'd like to add, Sean, that put a smile on some of our faces when you said under 65 is young.
Siva, I can still modify the slide. Apologies about that. Yeah, it's not supposed to be like that. So let's take away that hope. Let us agree on something, colleagues. In my last 4 slides, there's a slide that I highlighted that emphasizes that there's still residual risk. There's still high residual risk. In a way, I'm agreeing with what Siva is putting up front. I'm saying that I won't correct you. You are right in that there's something we're missing in this whole assessment thing. Either we need new biomarkers, or, of course, we need either a much more comprehensive way of assessing our patients. But the bottom line is that lipids still contribute that component of cardiovascular disease. And why are we seeing that? And why am I agreeing with you, Siva? Is that we're saying that in some cases, 50% of patients who have achieved treatment targets are still presenting in casualty with cardiovascular events. So there's something we're missing, either the biomarker that we are using, which is the current lipid profile itself, because we need to critique it itself, and that's why there's a move now into saying that, why don't we also add the non-HDL calculation? Why don't we add the ratios? Why don't we add apoprotein? Also, we need to be looking at other endpoints, as Siva says, but we now know that also there's other things that we need to assess other than just the lipid profile, and we combine them together in order to get a better outcome. At the moment, the only thing that's still going with the Framingham study is its history and its performance over time, and the newer ones that are now introduced by the European Society, we need to be fair and say that why are we then presenting options that are unaffordable in our region that cannot be afforded? Not that to say that we are rejecting them completely, but we need to continue to look for cheaper ways of assessing our apoproteins, for cheaper ways of introducing some of these approaches so that we can get a better outcome. But your point is made, Siva, and thus we are saying that residual risk remains a problem. And also we are saying that residual risk patients who have got high residual risk, those are the candidates for referral so that we can actually try and get to the bottom of it from our much more experienced colleagues in cardiovascular. I need on a marketing side,